thank you all for coming here today. You hear me well?
Yes.
Everybody perfect. Thank you for the care indeed for make this happen and inviting me to be here. I mean, it's so pleased to be here. I mean, before I start, I know the care indeed for many years. I worked with them in the community because we have a lot of mutual patients, and they've been taking care of my patients amazingly. I mean, this is such a wonderful team, very approachable, very comprehensive about the care, and I'm so thrilled to know them in this community. And thanks to Care Indeed people and the team for all you do for our senior community, especially in this area. They asked me to talk about kind of like a more treatment options that we have regarding Alzheimer dementia. As you know, I'm going to talk about it. We have different type of dementia, but it's mainly focusing on Alzheimer dementia is one of the most common for us. And then we're going to talk a little bit about what does mean with dementia, what does mean with memory loss, and then what also available these days regarding new option of the treatment. We talk about first some of the definition, because a lot of people ask about mild cognitive insufficiency. Used to people call it senile dementia or senile memory loss. This term is actually not valid. We don't have senile memory loss anymore. There is a normal aging brain versus the disease. What is Alzheimer's, staging of the dementia, and also conventional treatment. Are you seeing, or I'm too tall that you're not able to see that monitor? Because otherwise we can move it a little bit, the desk if you want, because I don't want it to block it here. And then we'll talk about conventional treatment that we have so far for Alzheimer, and also the new treatment, especially focus on amyloid monoclonal antibody, which you are aware of. This two new treatments are available right now in the country and many other places in the world, and what's going to be the way toward the future. It's an important topic. You already know that. I don't want to go on details. It's on growing aging population all around the world, and that means that technically by 2050, which is actually, it's very interesting. When I started my work as a geriatrician, and when I was doing the public lecture and all this stuff back in like 2009, 2010, when I talk about 2030, I said, okay, we still have 20 years to get there. But then when I nowadays days, when I'm talking about 2030, which is 2030 is going to be a very critical year for us in the Bay Area. The main reason is many of the Bay Area populations will actually exceed 85 years old, and all around the county, Santa Clara, San Mateo, and as it's going to be require a lot of need and resources, which hopefully we can make it another 5.5 years. I'm not sure about that, but it's been talking about it from many years, but hopefully in the next 5 years we're able to have some more resources for the people in the Northern California. Now, nationally, globally, 2030 is going to be a very critical point actually, because the developing aging population in the growing aging population in developing countries like India and China is exceed of like 120%. And technically, many of the developing countries are going to have a significant aging population. And when you talk about aging population, that means the risk of the neurodegenerative disease, including dementia, is going to be higher. That means that there's going to be more need for resources to take care of the people with dementia. Hopefully, it's just a different topic from what we talked, but these days are the presidential debate. If you have any opportunity to raise your hand and ask them this very important question, what do you guys have a plan for future? And the only things I've never seen in any presidential debates for all the years that anybody address about what their plan is about the growing aging population and the resources, and nobody even addressed that. You can look at the media; they're talking about every single thing except this issue that is going to be extremely important. Now, let's just come out from some numbers and look at the normal brain, because that's, in order to understand the dementia, it is extremely important to understand how our brain structure is. The brain has a two section. Technically, one section is the gray section and one section is the white section. When you look at the CT scan, when you look at the MRI, you can see it's a gray and white color. Now, gray section is a 40% of the brain, is actually started the gray section in the beginning of life, from the fetus life, okay, all the way till late 20s. Technically, we're all going to be done any construction, any developing of the gray section around the age of 29, 30. Some people are very lucky, they still extended at 31, 32, but technically, very straightforward statement is here. Brain start to become retired, not at the age of 65 when you enroll in Medicare, at age of 30 years old. Technically, the brain expand at 30 and stop expansion as of 30. The next of the brains will be white section, which is a white section is very different. It's technically, white section is starting in the late 20s, and it technically is important for information from different part of the body. But what we talk about, processing information, multitasking, many other things as far as learning, is all going to go at age of 30. Now, it doesn't mean that after age of 30 and 40, you cannot learn new things. You can learn new things because you expand it till 30, but technically, you're not having a new gray section after that. And this is exactly the way it is. Now, this is going to come a lot of topic here, which is not related to that. A lot of people talking about, should we let the kids drive at the age of 16? Because it's still the brain hasn't been developed yet. There's a lot of neuroscientists discussion about that. Probably the best time that we let them drive will be around after 25 years old, because they've done many studies. Actually, UC Berkeley done a lot of studies, showed that the brain reaction time at the age of less than 25 is extremely impaired. That's why when it comes to the car accident, speed, and controlling the car, the kids at like age of 20, 21, they're not going to be wise to controlling cars compared to somebody at the age of 30 years old. That's a brain structure. This is, again, it's not related, but technically you can understand why this is important. That's why the best age of the education, the best age of exploring, the best age of the developing neurons in your life. I will always say the best time if you want to date, you want it to fail, you want to do whatever, is actually between 20 to 30, which is all the gray section is expanding. And you can develop tons of neurons and a lot of experience that you can spend them for the rest of the life. But when you look at the brain structure, I don't want to go on a lot of physiology, but technically when you look at the brain, there's a different lobes in the brain, which is the different color you see here. So you see frontal lobe in the red color, temporal lobe in the yellow-orange color, blue is a parietal lobe, occiput is the green, and the cerebellum is a balance coordination, and the brain stem, which is heart. Now, let me tell you a little bit on here. The first thing is like a frontal lobe. The frontal lobe is a very, very important lobe that is the last thing in our life that is start to develop, and the first thing in our life that we're going to lose. This is normal. There's nothing to do with dementia. It's a normal aging brain. This has happened to all of us. This is all the thinking, memory, behavior, and all the movement is really going to that executive function. Like, for example, I'm acting as a physician. I practice as a medicine. I can see my patient. They're all located in the frontal lobe. And the minute I'm going to lose my frontal lobe, then my patient needs to think about a different doctor. And when it comes to the temporal lobe is also very important. I will tell you in the next slide. The area for the short-term memory is actually just lying down here in the temporal lobe. It's a very important, anything learning, like for example, you give me this computer and I'm trying to figure out with this computer, or you have an instructor to show me what are the keys, how can I operate this computer. They're all going to this area of the brain. A parietal lobe is a language and touch. All the speaking, all the feeling is actually there, and the back of the brain is all about vision. And in this part of the brain is the cerebellum, which is the balance and coordination is there. The people get Parkinson's disease, for example. Have you heard about that? The Parkinson's disease is actually technically affecting this place. And many of, like, for example, when people get Alzheimer dementia, later this area is also going to be affected. I will show you why. And then that's why we see that they have like a shakiness the gait's going to be impaired. They're going to walking like this, and they're going to be much slower. It's all going to be here. They have a multiple fall. It's always you hear the person fall down. It's all related to that area when it becomes degenerated. That's very important. It's not related to our topic today, but I just want to give you one educational, again, the hint here, one educational point here. The hearing and short-term memory, they are exactly next to each other. They're neighbor. Like the next door is the hearing, this door is this inside is the short-term memory. What does it mean with that? Brain has a mechanism. Whenever there is some part of the brain is not working well, brain always get the troops from other side to help the side that is not working well. For brain, two sensory is the most important sensory. Is vision and is hearing. And do you know why? Because even we're living in modern life, even we're living in the city with electricity and all this stuff, and thanks to Thomas Edison brought up the brightness for us, technically brain, for brain, we're still living in cave. We still have to be careful at night. If a wild animal is coming, we have to hear it, but we can see it and we can run away. That's why for brain, this two sensory is the most important sensory. Whatever happened to the brain, always make sure this two sensory is going to working well. This is good, excellent, but there's a problem. The problem is that the short-term memory section is exactly next to hearing. Whenever our hearing is going to be in problem, brain always send the troops, which is neurons, from short-term memory to the hearing section to compensate that. Is it good? No, it's perfect, but what does it mean? It means that if I have a hearing problem and I don't treat it, the first thing that's going to affect it is going to be my short-term memory. I'm going to be much slower in my learning, and I'm just wondering why, because I haven't treated my hearing well. It is so important. That's why I'm always advised to my patients when they come at 65, 7 years old, or even 6 years old, that if you brush your teeth twice a day for all life till today, the important thing is that your hearing aid is more important than brushing your teeth. Okay, that's very, very important for you to take care of your hearing, because otherwise you're going to lose it in your brain. And a lot of time is irreversible. That's why you need to think about it. Again, not related to that, but I just wanted to bring it up here. Now, as I said, in the middle of the temporal lobe, there is a place called hippocampal area. Is exactly the place that is all the short-term memory. Like whatever you hear from me right now, it all goes here. Okay, if you like at the end my lecture, say, oh, that's fine, then you are absorbing some of them to the deep brain section, and you remember me, and you remember the content of my lecture. If you don't like it, your brain's going to delete it, so forget about it. It doesn't make sense. But technically, this is the area that all the information you get called immediate memory. This is exactly the way that we do testing. Like, for example, we do memory tests for a patient. We just ask them in the office, we give them 5 words, and then we ask them, okay, I'm going to ask you in 5 minutes that 5 words. They're all going to go here, okay? And if they still stay there very well, they're able to remember that 3 words or 5 words we call delayed recall. When somebody has Alzheimer dementia, I will tell you about that. This area is going to start to shrinkage and atrophy. That's why we do MRI, memory protocol, to look at this area. This is a very important area, and some people are bigger, some people are smaller, not related to our topic today. But again, in the different carriers, actually they have bigger hippocampal. Some carriers have the shortest. I'm always making a joke. The politician has the shortest hippocampal area. And but then technically, this is a very important part that in the brain. Now, a lot of things by aging can change. I don't want to go on details on that because it's going to be too much. It's a different topic. If Karen did invite me another time, I'll be happy to talk about normal brain aging. But the processing, the speed, it's a very important part. The visual spatial ability, this is exactly what we talk about when it comes to driving later of the life. We wanted to see if the understanding about the different area, and attention and many other. Attention especially is important because attention is exactly going to go to multitasking situation. Now, what happened, as I explained to you, is on late 20 years, when we get 29 years old, 30 years old, the volume of the brain start to shrink. And this is normal. That means if I have my MRI today, okay, I'm in my 50, if I have my MRI at 30 years old and 40 years old, I can easily see every 10 years my brain is starting to shrink. And that's absolute. We are like that, apes like that, gorillas like that. We're all in the same boat. There's nothing that, oh, my brain never going to shrink. No, that's not possible. The brain has to shrink. And I will tell you why. Especially that happened in that red section I said, prefrontal and frontal cortex start to shrinking more. And again, definitely its atrophy is going to affect more on the area that I explained to you. Executive function, working memory is going to be like that. Now, the other part that is going to be decreased is a blood flow. Blood flow also is going to go less and less every decade. 5 to 20%, the blood circulation is going to be less and less. And that's very important because a lot of time you hear, like for example, you go see a doctor, we talk about high blood pressure. Somebody has high blood pressure. We say, okay, it is important to control the blood pressure because technically your brain has reduced the 5 to 20% of blood circulation normally. But if you have uncontrolled high blood pressure, that means the chance of the low blood flow to the brain will be higher and higher. It means that technically if somebody at the age of 40 and 50 and 60 has a high blood pressure and never taken care of that, the risk of the dementia will be much higher at the age of 70 and 80 because the blood circulations will be lower and lower and lower. No, but the good question is here, why this is happening, why we lose neuron, why the shrinkage is happening. Well, technically, this is what we call apoptosis. Apoptosis means falling off, means that technically every single cells in our body designed to die, and that's true. From the beginning of the life, we're all designed to die every single day. Now, what does it mean with that? We're still alive, I'm still alive. But what happened is that technically the cells is going to the cycle, which is a lot of enzymes involved, a lot of the other stuff to be involved, oxidant agents to be involved. Technically, the cell's getting the signal to die. Now, let me tell you an example is here. For example, a child at the age of 8 to 14 years old, they lose 20 to 30 billion nerves a day. A child, okay? At age of like 50 to 70, we're almost losing around 70 billion nerves a day. But today, till 12 o'clock tonight, I will lose 70 billion nerves tonight, okay? I will produce it again, but it's always about discussion about production, supply, and demand. If my factory is able to produce more and more, then I'm able to compensate that 70 billions that I'm losing today, Thursday, till Friday. I'm able to back again that 70 billions. Every time when you take a shower, you lose a billions of skin cells when the water comes to your body, okay? When somebody has bowel movement, what is bowel movement is? Billions and billions of all the dead cells. From esophagus, stomach, intestinal, from the mouth, they're all going to the bathroom. Same thing as a urine. We technically, as every day, we are putting billions of the dying cells away. That's the way it is. Now, when that balance gonna be more dying cell, less production, that's the time our body is start to become more frail. And if in that the speed's going to be very high, that's exactly the theory of dying. That we die. Like people get heart failure and the heart to stop to working. Because the production of the muscle cells of the heart, it will be less than what they needed. That's all about the theory. Now, technically, this has happened from the beginning, and this is very normal, and that happens specifically for the neurons as well. When the neurons get the dying process, when you look at the one nerve is like a tree. It has branches, leaves, and it has a stem. But technically, when two neurons getting connected to each other, because of the shrinkage, because of the atrophy, the signal, because of what the neurons does, this electricity goes all over between neurons. That the speed of electricity going to be less and less and less. That's why a lot of the things happen with the atrophy of the brain in a normal situation. The first thing is a processing the speed. I'm always having this complaint, why I'm slower than before. 10 years ago, I was much faster. I was able to do multitasking. I can't do it anymore. And I can do it. I mean, I just personally said, I was doing emergency room, I was doing ICU. I remember when I was like ICU, doing hospitalist ICU, going down to admit patients at nighttime. In my 20s, late 20s, 30s, I was just super active and writing notes, go procedure in ICU. I cannot do it anymore. I cannot do it anymore. If I have to, if now when I'm, for example, writing a note and somebody texts me at the same time and there's somebody bring the paper, I get so nervous. But I was not like this 10 years ago. I was able to handle all of them at the same time. I know what is going on. I know what's happening to me. It's the processing speed is getting slower. That's a normal situation with aging. And this is exactly that a lot of people are actually noticing that. And again, the part of the brain which is affected significantly is executive function, especially for people that they have dementia. This part is yellow: attention, working memory, planning, organizing, impulse control. This is very important because, as I said, planning is, for example, because of people like even aging or dementia, there's always planning, organizing. My office consultation to visit, the traffic is around Thanksgiving to Christmas. And why is that? Because the kids coming to visit the parents, and the first thing they notice, my mom always able to throw the party for like 30 people. This year I came, my mom was not able in initiating anything. She was so overwhelmed. She couldn't put the stuff together. She just forgot the recipes of what she was doing all the time, and she started to become nervous. And I know what is the problem. The problem is the frontal lobe. The planning, organizing things are just getting worse and worse. And then attention and focus is also going to be affected. As I said, multitasking is going to be affected as well. As I said, age-related, slow processing the speed, reduced ability to ignore irrelevant information, decreased use of the strategy to improve learning and memory is going to happen here. I'm going to pass it here. The only thing is here is a type of the long-term memory that we have. For example, we have procedural memory. Procedural memory never going to change by aging. Even people get dementia till advanced dementia is not going to change. What does it mean? It means that if I was like a biking or I was skiing when I was a kid, and I'm never able to ski again till I turn 7 years old, okay? And somebody just put me in a mountain and give me the ski, or somebody give me a bike, it takes only 2 minutes to 5 minutes for my brain to do it again, because it's on the part of the brain they call it processing speed. I see that a lot in my patients that have been great instrument playing, like a piano player, violin, and I see that when they go to a facility they haven't played for a long time, it just takes for them 2 minutes to just again a little bit practice on the key, and then suddenly you see the music's coming on. That's exactly the processing speed. But the part of the memory in the long term is going to be affected. One of them is episodic memory, the personal information. When was our anniversary? What was the birthday? What happened when I went to the college? I mean, the year. That's kind of episodic memory. It's a good excuse if you forget anniversary or birthday anyway, you can say. It's part of the aging process, don't worry about it. And the general knowledge about that's going to be affecting more. Now, everything I said, just introduction, the presentation just started. The mild cognitive insufficiency is not normal, is abnormal. It's technically the earliest stage of the memory loss or dementia, and it's technically is a subjective and objective finding. Sometimes it's something that the person himself or herself finding that I'm forgetting more, I'm losing my stuff more, and it just becomes concerning. Or objectively by people, like especially when you are again, kind of like not able to keep up on the appointments, or some of the instruments going to be, like for example, instrumental active daily living, not at the level, because in the mild cognitive insufficiency, the person is completely able to do all the basic daily activity. It means that basic daily activity, able to go to the toilet, shower himself, herself, able to dress himself, herself, feeding himself, but even able to use the cell phone, able to taking care of the bills, paying credit cards, taking medications, go to the doctor's appointment, driving perfect, do the laundry, all the instrumental, they're all intact. But technically, it's starting to have some issues, like for example, remembering names, words, and kind of like putting the object in somewhere and come back and say, where did I put my car key, and just keep looking around. These are kind of like starting the problem. There is a chance of 10 to 15% these people may progress toward dementia. Many times it's a reversible situation. It's related to something that people are doing, like for example, sometimes it's related to medications that they're taking. Sometimes they're taking medication for sleeping aid or anxiety medication, or kind of not all anxiety medication, but some sort of anxiety medication that can affect the memory, and or especially sleeping medication can increase the risk of the myocardial insufficiency, or some other medication that what we call anticholinergic, like a medication for bladder incontinence or all this stuff. They can affect the memory, but that can be the reason. If you can get them off early, then the situation is reversible. But technically, somebody from mild cognitive insufficiency, which is completely independent, it can go to mild dementia, moderate dementia, and severe dementia. But if that comes to discussion, what is exactly dementia? Everything I said is an aging brain that we're losing the neurons, but technically, dementia, it's a general term. It's a very, we don't use the word of dementia anymore. We call it neurodegenerative disease. Technically, it's a disease that affects not only the memory, but also thinking and also social ability. And that's exactly going to be impaired significantly if people get dementia. Dementia, by means, is exactly what I said. When the speed of the neuron loss going to be so high that a factory cannot produce it and replace it, that means it's a dementia. Technically, when I said kids are losing 20 to 30 billion nerves a day, in the demented patient, that will be 300 to 400 billions a day. But they cannot replace it. They cannot replace it. And that's why this is going to be the beginning of the problem. A lot of disease can cause dementia, but the 5 of them is a very famous Alzheimer mix, which is a type, which is majority of dementia is actually mixed now, is a combination of vascular and Alzheimer, Lewy body, and the frontotemporal. The frontotemporal usually happen in the younger population. Lewy body, it's a very different topic. It's a very nasty dementia. It's a type of dementia that it's so hard to be treated, and the prognosis is actually poor. The people have much higher chance of dying faster for the Lewy body dementia. And Alzheimer is one of the most common ones, but it just technically is growing. It's population-wise, as because of, again, as I said, the growing aging population, the chance of dementia is actually going up globally everywhere. And that technically is one of the leading cause of death today. Now, what happened in the Alzheimer situation? Years ago, which till today nothing happened so far, this is Dr. Alzheimer. He was a neurologist working in Germany, in the city of Frankfurt in Germany. And there was a lady came, admitted, she was 55, 56 years old, and she was admitted in psych unit in the General Hospital in Frankfurt in Germany. And she was diagnosed with schizophrenia because she was hallucinating, she was delusional. Dr. Alzheimer was very suspected about the disease. The presentation of this lady said, what happened? This lady has a severe short-term memory problem, but also has some visual hallucination. That couldn't be a schizophrenia. It's something else is going on, because the people with schizophrenia, they actually have a great memory. The memory, short-term memory is okay. But what is that? And he was kind of puzzling about the situation. This lady passed away in that hospital, and then he got the permission from the board of the hospital to do autopsy of the brain of this lady. And this is what he found. The beginning of the disease of Alzheimer disease, or which we call it Alzheimer dementia. What he found is just very fascinating. Inside the neurons, he found something called amyloid plaque, which has nothing to do with the schizophrenia. That's why he said this is not a schizophrenia, this is a new disease, and he called it Alzheimer. And this is exactly the amyloid plaque, this kind of abnormal protein that's not supposed to be there, but is there. And what it does is technically inside the nerves, as you see here, is a healthy neuron versus the sick neuron. You see all the yellow plaque, it's going toward, and then technically cutting the signal. It's like, for example, in this building right now, if I have someone to come and cut the half of the electricity wire. Half of this place is going to be dark, half of this place is going to have electricity. This is exactly amyloid plaque is doing it. And then later they found tau protein, which is a tangles of the protein as well. And it's the bad things about this is that protein abnormal, they have tendency to go and grow in the area that is affecting memory. Okay? Like for example, you never see someone that have vision problem with Alzheimer beginning. No, because it doesn't go to the back of the brain. It likes to always go to the frontal of the brain. Why? Nobody knows. But that's why we call Alzheimer disease, which is technically, as you see, as I explained to you, that's the neurofibrillary tangles and amyloid plaque going to be affecting that. It's just, as you see here, I'm just probably going to just talking here. As you see, the blue color is the amyloid protein, and the red is a tau protein. Tau is usually happen when the disease is going to be more progressive and advanced. Amyloid is started early. This is from Lancet Neurology, and this is one of the scariest slides. Oh, did I say scariest slide? Okay, come back. This is really the scariest slide, and I'll tell you why. The reason is that when you look at this, that person is memory-wise completely normal, and the mild cognitive insufficiency is here, dementia is here, okay? This is clinical disease, like person start to have short-term memory loss, maybe at 7 years old or something. The scary part is, as you see in this color, amyloid protein and tau protein start decades before the short-term memory loss going to start. Now, all the scientists, they agree. If somebody diagnosed with Alzheimer's dementia at age of 81, 75, 90 years old, the tau protein and amyloid protein, they actually start to develop when they're in 50s and 60s, or even 40s. Not at the time they're turning 60 and 70 and 80. Decades and decades ago, that started. Accumulate, but the clinical stage start much later, decades later. Why is that? There's a lot of the theory behind that. Nobody knows. If anybody found today, it will be Nobel Prize winner, because we still don't know why the people at the age of 40s, 30s, or 50s, or even 60s, they're starting to have this. There's a lot of theory which becomes much more popular right now. There's a lot of theories that discuss. One of them is autoimmune disease. They think about our immune system is attacking to the brain for some reason. Like in Germany, a lot of the German neuroscientists, they think viruses. We get exposed to some viruses in our midlife or 40s and 50s. We're not aware. We got rid of the virus, but our immune system is still attacking. And that's why they're attacking the brain, causing the release of abnormal. They're talking about herpes simplex virus. It's just HSV1, especially if a lot of people get it, can happen through the oral or genitalia infection. They're thinking about there's a very high possibility herpes virus simplex is going to be in the body, or immune system start to attacking. That cause destruction inside the brain, cause the amyloid protein. They're talking about it. We're going to probably see a lot of autoimmune related due to COVID and SARS in the future. In the next 20, 30 years, maybe people getting COVID is a possibility that they may have later. There's a lot of theory there. But technically, autoimmune disease is one of them. They said possibly something in environment that is there. We're not aware, but our body start to attacking again. Nobody knows. Anybody find it? That's going to be amazing. But I don't know. We're able to scientifically find it in the next decades. Maybe none of us in our life. Metabolic syndrome is also becomes very popular. They're seeing that people have possibly insulin insensitivity. It doesn't mean diabetes. A lot of us, we still can be not diabetic at all, but inside our brain, we have problem with insulin distribution and sensitivity. And they were thinking about maybe our lifestyle at age of 40 and 50 years old or 60. We have a lifestyle. We go check the doctor, oh, your sugar is fine, but inside our brain, whatever it is what we're eating that we don't know, people talk about sugar, artificial sugar, all the soda, or all the things that, it's all theory. Don't believe any of them. I just say that there's a theory that they're talking about insulin. So that becomes popular, especially as I tell you in the next slide. There's a new treatment shows that people using diabetic medications is actually protecting the brain. That was just presented, I will tell you, just 4 weeks ago in the International Alzheimer Association in Philadelphia. And it shows that the use of GLP-1 agonists like Ozempic or like other this medication like Victoza is actually protective for the brain and cause the less possibility of developing dementia. But again, it's a smaller study, it's still on a lot of question, and there is another study is running in the next 2 years, I believe you're going to see the result, is on a phase 3 right now in Boston. I know the entire team that they're doing, a very good friend of mine, and they're doing the SGLT2 inhibitor, which is a kind of diabetic medication, given at age of 50 and 60 to see if that's going to be helping the brain to not getting affected. But technically, there is definitely some link to insulin insensitivity. A lot of people say it's inflammatory. There's inflammation happened to the brain that we have no idea what happened, probably very related to autoimmune. And a lot of people say, no, forget about it. None of them is vascular change. The small circulation in the brain start to break down at age of 50 and 60 for some reason. Can be stress, can be high blood pressure, can be lifestyle, can be smoking, whatever, just to putting off, can be alcohol. A lot of people are talking about alcohol can cause the vascular change, and later, decades later, starting to have the problematic. There's going to be a stage of dementia. I don't want to go on detail, but technically I just want to say that this is helpful to know, and this is especially for people working in the again caregiving industry or people for the hospice or anything like that. Technically, we have 7 stages of the dementia, and stage 1 or 2 technically is nothing. The stage 3 is the time that the early Alzheimer's start, and usually the people start to noticeable deficit in demanding job situation. This is usually lasts 7 years, and the people move toward mild Alzheimer, which is around 2 years, and moderate Alzheimer around 1.5. Technically, in the mild to moderate is the moderate is, for example, and I always say that, for example, in the mild, if you have some task, for example, handling finances, traveling, planning parties, that's mild. I'm always asked the question, is your mom and dad or your partner able to choose the proper clothing? That is always, if they say no, we have to give it, then it means that they move to moderate. This is very, very sensitive. And stage 6, which is moderate to severe, is technically assisting with dressing, bathing, toileting. This is the time that when assistance needed, they have a problem with fecal incontinence, urine incontinence. This usually is a very painful stage, but 3.5 months to 9.5 months. And then they move to a stage 7, which is a severe stage. This is the time the people not able to speak more than 6 words is intelligible, that you can understand what they're talking about. They very loss of ability to walk, sit up, smile, or even sometimes you see to hold the heads up or even the body. This average is around 1 to 1.5 years. These people at that stage will be qualified by federal regulation to be on hospice care, which is technically so important, because when the people get dementia, when they said, can we provide hospice, are they on a stage 7 or not? Which is always I'm asking, can they say 6 words? If somebody able to talk, somebody's still able to sit up, hold their heads, they're not still qualified for hospice. CDR is another dementia skills. No conventional treatment so far we have, we're using the medication called cholinesterase inhibitor like donepezil, generic name, brand name is Aricept, rivastigmine, Exelon is the brand name, memantine is Namenda. Let me tell you, they're not curing the problem. We don't have anything to cure the problem. But when I comes to argue with why this medication can be helpful, they help in the first couple years to do a neuroprotective situation. The people are taking this medication, they do better as far as like behavioral and managing a lot of neurologically compared to people who not taking it. We have the experience, like for example, when we give this medication for years, and we see that, and this is exactly American Academy of Neurology has a statement, when we stop this medication, the people decline faster. That's why it is so important to, and a lot of people, I see this mistake a lot in the practice, when the patients, like for example, referred to me by the primary care doctor, said, we stopped the Aricept because it didn't help with the memory. So it does not help with memory. It's only a neurostability. It helps through the course that you have less symptoms, especially like visual hallucination, agitations and many other symptoms if they're able to tolerate. But again, the side effect can be high, especially diarrhea. It can drop the heart rate. It can increase risk of syncope. That's why it is important to know that. Technically, when it comes to the treatment, there's cholinesterase inhibitor comes to the page. There is a memantine comes to the page. But there are a lot of behavioral things, which is including delusion, hallucination, depression, apathy, anxiety. This is a totally different topic, this is my favorite topic. Why dementia is not only about memory loss. Dementia is actually not about memory loss. About 20 to 90% of people with dementia, they have behavioral symptoms. Part of the dementia and is expected symptoms happen, which they can be extremely agitated, they can be aggressive, they can be withdrawal, apathy, and depression, and many other things. And this is the time the psychotropic medications come on board. But now, as of 2023, it's actually before, technically we have 3 amyloid monoclonal antibody treatment, which is aducanumab from the Biogen, Leqembi or lecanemab from Eisai, which is a Japanese company, and donanemab, which just got approval on July 2nd, 2024. This one got approval, accelerated approval at January 2023, traditional approval in July 2023 is in the market. We do the infusion as well. Aducanumab, I will tell you that they got an accelerated approval, but unfortunately it didn't go very well because it was the first FDA accelerated approval. Is technically based on the 2 phase 3 trial, Engage and Emerge trial. And it's again, one of the things that happen in these people is that technically when we give them any amyloid monoclonal antibody, this is for aducanumab. For example, you see the person at the baseline, you see all this red area? This red area is all amyloid protein in the PET scan, when they do amyloid PET scan. And then they started to, when they started to do the treatment of these people, as you see here, like a 10 milligram per kg, you see that all this red area has gone up. They're all clear. Then technically what this monoclonal antibody doing is goes to the amyloid protein and it get them out, resolve them. It's a targeted therapy they call. And then again, technically as of 54, it has effects on the memory a little bit, but it technically on the many staging of the disease, it technically make them stable. The problem is that for aducanumab is the difference between Emerge and Engage trial. One of them shows is effective, one of them shows is not. Then in January 2023, it was on 5th of January, the lecanemab came, New England Journal of Medicine approved it. The next day, FDA committee is actually made the accelerated. And technically, this is the IG1 monoclonal antibody that is technically goes and work on the monoclonal antibody. The interesting thing about lecanemab is effect on the memory because it's 18 months of infusions or twice a month. When we look at the placebo and then look at the control group that have been on the lecanemab, the people on control group is around 30% to 40% better compared to placebo in a stability of the memory. What does it mean with that? Like in 1.5 years, they notice that people on placebo, they decline much faster. There's a high possibility they go to memory care much faster. The group on the treatment, they're still able to be independent enough some of the function. They're still losing memory, but it's not as fast as the other group of the placebo group that is not on the treatment. And that's why, that was the reason FDA got approved that. And then, and it was the first time that we see, I know it's not very significant, but it's the first time that we have seen there is a difference between placebo group versus the control group that has some improvement. And that's based on the clinical trial that has happened. This is the New England Journal of Medicine 2023, is around 1,800 people, control group and the placebo group, and they continue that. And then they look at the data. One of the things is that technically, as you see here, the amyloid PET scan significantly lower, like the amount of amyloid burden came down significantly lower on lecanemab. And then when we look at the, for example, some of the ADAS score, we look at the memory, these are all the things that we do a lot in research, we see the people on lecanemab overall, they're much higher compared to the placebo group. And again, ADAS, MCI, ADL score, the group of the lecanemab has been higher than the placebo group. That was very interesting. That was exactly the thing that they said, oh, okay, well, that's the beginning of the story, because now we have this issue. But there is a catch. The main issue is going to be the side effect, which everybody asks about. What is the side effect? The side effect is that what we call ARIA is amyloid-related imaging abnormality. What does it mean? The area they think about, this antibody goes and attach to the amyloid protein and try to absorb it. In 21% of people, there is a chance that they may have swelling or they may have microbleeding. May just start to bleed there. No. The microbleeding and swelling is all self-limited. It's not something that makes the people to die. It's actually when you stop pause the treatment, it's all going to be self-limited. They're all going to be absorbed by itself. It hasn't had a massive. There's one case of the massive bleeding during the trial that actually the person died. I think it was in Canada or Europe. But the person was taking blood thinner medication for the heart condition. And that's why that combination made, this is one of the indication of this medication. If you take blood thinner medication, it's going to be excluded. You're not allowed to do that. But technically, this is the two things that we're looking at this. And ARIA is on, and aducanumab is going to be much higher, it's a 40%. In lecanemab is around 21. I will tell you in the donanemab is around 27, 28. It's high risk for the people, they have ApoE4, both ApoE4, I don't know if you know about it, but there's a gene called ApoE, okay? And the ApoE has a 4 components, ApoE1, ApoE2, ApoE3, ApoE4. 1 or 2 are perfect, nothing to worry. 3 is neutral. 4, the people have ApoE4. They have a 10 times higher risk than general population that develop Alzheimer dementia, okay? But if they have family history. Now, if they have 2 ApoE4, the chance is going to be higher. But not necessarily everybody with ApoE4 going to have a dementia. There's nothing genetically found that somebody had, except the frontotemporal. The frontotemporal is different. We know the gene, okay? And somebody has the gene, 100% going to get dementia. That's one of the very interesting topics, because even there is a discussion right now in many places, including Europe, that somebody has a family history of frontotemporal and has the gene, can this person terminate their life earlier before go to the process of the disease? And that has been discussed in many countries, in many places, even in the United States. I've been involved with that. It's a very painful process because definitely they're going to get the disease. Unfortunately, there's no chance. But the ApoE doesn't mean, if I have an ApoE4, my mom and dad didn't have a dementia. They both died of something else. But if I have ApoE4, well, I didn't have family history, I have ApoE4, I just know myself that I have a higher risk compared to the general population that I may develop dementia. But it's good to know, because then if there's any irreversible things, like for example, if I have high blood sugar, diabetes, high blood pressure, if I'm drinking too much alcohol, I can kind of change my lifestyle to make sure I'm not going to go through that. But it doesn't mean you have it. But if people have 2 ApoE4, there's a chance of the bleeding because of the monoclonal antibody is going to be higher. And most of the cases are asymptomatic. That is true. I started this treatment as of last September. I have many patients that are actually on this treatment. And first of all, knock the door. I haven't seen any ARIA so far in the patients that I'm doing the treatment. I have one lady that I remember exactly, last Christmas, exactly on the 24th of January, she went to do her MRI routine for the checking. I was 6 p.m., Stanford radiologist called me and said, hey, Yadi, your patient had a severe swelling in the brain now from the previous MRI. And I just called the lady that she's actually getting treatment. She was playing golf. She was absolutely okay. She was asymptomatic. I called her and said, Dr. Yadi, it's Christmas evening. I said, I just want to tell you that unfortunately MRI she was swelling. Are you doing okay? And she said, no, I'm absolutely okay, no symptoms. So I just want to tell you that we're going to pause on your infusion. No more infusion. We have to wait for 4 months and repeat again MRI. She was totally asymptomatic. We repeated again MRI. and she was completely clear, the swelling gone. And then we discuss about do you want to continue the treatment or not. But again, these are the things that the physician and patient can discuss about that. As I said, ARIA can be 21% of lecanemab, and that's something we need to look. The people are not going to be candidate for that. The people are blood thinner medication, warfarin, Eliquis, Paradoxa, Xarelto, not at all. If somebody has within a 1 year any recent stroke bleeding, this medication approved from 55 years old to 90 years old, okay, by FDA. If somebody's 91, 92, does not qualify for the treatment. That's what we call geriatric. But anybody, for example, I have patients at age of 88, and I'm telling you, you know what, till you're going to finish the 18 months, you're going to be 90 years old. Do you really want to go through the treatment? And and we discussed about that. But this is something, or somebody has cerebral amyloid angiopathy, which is a small bleeding in the brain, and then cause, this is the neurological, they cannot be that. Okay, I'm going to pass this with just, infusion is twice a month, and it's a 1 hour infusion, and they always need to be on that. They need to have 3 MRI based on FDA and also Medicare at the 5th, 7th, and 14th infusion to look at for the microbleeding and the swelling. The Medicare is actually approved that now, and they're all covered by Medicare right now. There's some of the side effects, maybe reaction to infusion, headache, diarrhea. Usually we use the pre-medication, like we give them Tylenol in high dose prior to the infusion, and they're actually doing well with that. And again, it's technically for people that have mild situation. If somebody has moderate to severe, they're not going to be qualified. It should be MCI and the mildest stage. It should be evaluation. There is a genetic test required by Medicare, and also the national committee, that's the way they approve that. You need to test it for APOE. There should be a memory test and functional assessment needs to be done. They're all scored, needs to be do on the Medicare registry, because they are looking at the registry as well, and they're looking at the potential risk, and they do that. And then Medicare cover 80% of that, and if you have a supplemental insurance, it's actually just covered. Technically, that's all the infusion is all covered, and also the MRI is also covered. Is everybody candidate? No, it's not everybody candidate. It should be evaluated because it should be exactly on the mildest stage. If somebody moved to moderate stage, is not going to be the case. If somebody has Lewy body or vascular, they're not going to be candidate. That needs to be determined. That is this the Alzheimer, amyloid? That's why the people need to take it. I'm taking blood thinner medication. Should I stop it for 18 months? We do not recommend that, because the risk of a stroke is going to be much higher to do the treatment for amyloid. If somebody can take baby aspirin, can I take it? Yes, we can also do that. What happened to infusion is stopped? We don't know that. Yesterday, it was an article published for people on the clinical trial that they extended another 6 months, and they actually found that another 6 months they do much better, and the people actually stop the treatment after 18 months, they start to dropping as well. Now, that has been just published, but the Medicare is still approving even the extension of the treatment above the 18 months. How do I know I'm amyloid positive? You have 2 options. Either you do a spinal tap, which you need to go to the hospital or radiology. Usually I send it to Stanford neuroradiology. They put the needle in, take the fluid, we send it to the lab and see if his amyloid and tau protein is there. Or we do the amyloid PET scan, which is luckily now Medicare start to approving it. And you do the amyloid PET scan and see if there's any amyloid. No, does Medicare pay? Unfortunately not. But yes, the answer is yes in some circumstances. It depends on the code that you use, you can get it. The other question is, I don't have memory loss, but I'm amyloid positive. Can I get a treatment? There are a lot of people, they just go to PET scan, they have no problem memory, you test them, 30 over 30, they're perfect, but they have amyloid in the brain. The answer is, you can get it, the treatment. There are a lot of commercial insurance is also approving it. But the only thing is that there's a trial is running all around the country for people who are absolutely healthy and they only have amyloid protein. Stanford is running. If you're interested, go to the website. They're recruiting people that are amyloid positive, but they're absolutely healthy. They give them the treatment, see if that's going to help them to never develop dementia. But I know the University of Washington enrolling, Mass General is enrolling, a lot of them is actually enrolling. It's a big commitment. It's 18 months of infusion, which is twice a month. But again, that's probably is there. No, the donanemab got approval in July, and it's a once-a-month infusion. There's an article called Trailblazer Alzheimer 2. 40% of the patients actually did for 1 year. No decline in the clinical dementia rating scale. The number for donanemab has been very, very impressive as well, I have to say. But ARIA is a little bit higher, is about 28%. This is a beginning of the history, but again, it's not a cure. That's what I wanted to say. It's helped to slow the progress. But there's a lot of other things that we talk. For example, there's we have so far, all the study about tau antibody has been failed, unfortunately. There's a one in phase 2 is running right now, which is probably one of the best one is going, if we can targeting the tau, because especially protein tau 181 can be very, very responsible. And I can tell you, if we're able to get rid of tau and amyloid at the same time, probably we solve the problem. But we just technically Alzheimer's is going to be in a much better situation. We technically can announce that yes, we cured Alzheimer's finally. But the problem is that targeting the tau is really, really painful. But there is as I said, there's a lot of this study called metabolic. Is it the point to slow the progress? Yes, of course. It's a quality of life. It's about independent of the person. It's actually going to be cost-wise. It's going to be extremely important for family as well to think about moving to memory care much faster versus you can delay it. As I said, GLP-1 receptor agonist. It has shown some study. It just all in publishing. The GLP-1 again, as I said, like Ozempic and Victoza. There is an Alzheimer's Association just again in the international shows the Victoza in the phase 2b trial. It shows the Victoza appears to reduce the shrinking of the brain around 50% compared to placebo, which is amazingly. There was one of the best presentation was in the Alzheimer's Association International just a month ago. And there's a lot of the other trials is coming regarding diabetic medications at the end. Now, I finish here, and I'm happy to answer any questions. Thank you so much. Thank you. Hey, I think one question here. You have a question? Yes, please.
Yeah, so I follow the Commonwealth Club, and there's going to be a Dr. Paul Allen Cox, who's speaking tonight. He's got some research on the amino acid L-serine that helps block the effects of BMAA, which is the folding protein.
Exactly. I heard about it, but I'm not very familiar. I heard about this as well. Yeah, just going to be fascinating.
Yeah.
And hoping that it's going to be some trials is running and see if it's going to be effective. Yeah, but yeah, I heard about this, but I don't know about details because it hasn't been like in clinical trials.
Right.
Or the peer review to see if that affects us, how much it's effective. Yeah, is it going to be tonight in Commonwealth, San Francisco?
Tonight in Commonwealth, but it's also going to be available. I mean, they always
through the Zoom. Yeah,
right?
I've been there. I've been speaking there. Yeah.
Yes, I know you have.
Yeah, it's a very nice group. It's interesting speakers coming here. Yeah, good.
Thank you.
Please, question.
Yes, can the monoclonal antibodies for amyloid be prescribed to frontal temporal dementia?
No, unfortunately, no.
What's the best thing for
because if it's still the frontal lobe dementia is a different mechanism. It's not an amyloidopathy. That's why it is. It's not getting any approved. Now, even for Lewy body dementia, 30% of Lewy body dementia they can be amyloid positive, but it's still not approved for the Lewy body dementia yet. Now, I don't know what's going to change in the future because again, everything is started from fall of 2023 for all the approval and getting through the treatment. But there's no cure for the frontal temporal. There's nothing for frontal temporal dementia. Unfortunately, it's all supportive care, and they usually have a very poor prognosis. They die very fast. It's one of the invasive neurodegenerative disease, sadly. Please.
My question kind of follows that. In terms of lecanemab and donanemab that's coming out, have you seen any applications with mixed dementia, where people might have more than one type of dementia?
No, not yet. not yet. We haven't seen that. I haven't seen also in Europe. Technically, Europe is 6 months ahead of us. When we started in around September, October last year here, the Scandinavian countries, especially Sweden, started on like February 2023. They're actually ahead of us. They are going to release their data in the most, because they have the more opportunity to do in general population. Japan is also started in March 2023. I don't know if they have started on the mixed type of dementia, but it's kind of like still going. None of the countries has still reached to the 18 months, and they actually use it in other kind of dementia. That's why I'm waiting for the first release of data. I've spoken with a couple of my great colleagues in Stockholm in the geriatric department there, that they're actually doing the treatment there. And they're just sharing with me some of their experience. But we're all waiting for European to first release their data in general populations about slow progress and delay of the moving them to a care home in this population. And we can kind of like then see what's going on in our country as well.
Thank you.
Yeah. Please, questions on the
Hey,
back.
Dr. Ayadi, I was really interested in your genetic
Right.
counseling, the APE4.
APOE, yes.
And I was wondering what the qualifications of that would be for an individual just.
Anybody can do that. The problem is the coverage. The most of insurance are not covering it it's just out of pocket. Yeah, I know the Medicare Part B is not covering it. It's going to be out of pocket, but you can do the genetic test. Some companies are doing it. You can find it online. You can find it. Most of the companies that are doing this kind of genetic, they're all located in Southern California, but they have branches here as well, and you can look at it online. But if you go like a Quest Diagnostic and do Alzheimer, dementia, marker, genetic, genotype, the Quest is doing it. But again, the cost is out of pocket. I think it's around $200 or $200 to $300. I think so. The patients of mine, they went there. I think they paid around $200 to $300, but it's out of pocket. Yeah. They do APOE test.
Yes. Yeah. Well, the reason why I asked is because this morning I was listening to the news and they were linking cancer in individuals that were younger and younger.
I know.
They're seeing this spike, and they're contributing it to our food and just. A bunch of stuff in our food and preservatives and things like that over a long-term use and hormones and that sort of thing. And there's a part of me that is wondering, those individuals that have no history of Alzheimer's in their family, but we're eating differently, our environment's different, how strong that contributing factor is in developing cognitive impairments, especially if it starts 20 years prior to you showing symptoms.
Right.
So.
Yeah, that's as I said, it's the Nobel Prize winner question. But there's no question that food industry overall, what we see in North America, especially in North America, has effect on the health of the human being overall. Has negative effect. The way the industry of the production of the food is going on right now, having effect. Like to think about, just you can look at all the especially in California. I mean, you can easily find when you drive Highway 5. You can easily find all this ranch. I mean, all this farms area with the amount of the toxin that they use it. You can smell it. You can easily smell it. And think about that. This is all these are the food products that we all consuming. Wheat productions in this country. The pesticide that we use in wheat production, in order to keep them for a long time in silos, and all these things that we see, that definitely has a negative effects on the health. We don't know yet. These are the part of the medicine that are still very early to see that, but there's no question, since the food industry become more modernized, the people are getting more sicker for any kind of disease. That can be cardiovascular, can be metabolic, can be cancer, and that's why the first time we see this in the kids. that we never seen this amount of cancer in the kids before.
And
that's,
so with that being said, are neurologists seeing younger individuals
yes.
with Alzheimer's?
Oh yeah, it's much like, which is very interesting. That's a great question. I have, which I never had it before as geriatrician, always having patients in the older spectrum. I have many patients right now at 60, 55 years old in a severe dementia in the memory care, which I'm taking care of them. And it's very, very sad cases. Yeah. No, it is. Unfortunately, it is. That's why we see that this spectrum is actually extending to the younger ages. Yeah. But again, nobody knows is the food is what we have, is the food industry what we have, is causing them dairy products, the way that we are raising cows and all this stuff. There's a lot of things, a lot of theory that people are talking about. But it makes sense. It makes sense that the way that we eat, the type of food that we eat, and actually we're eating all around, the industry of the food production is not healthy. Not again necessarily cause dementia, but in many other diseases, we can easily see that. Yeah. Mm-hmm. But that's going to be $1 million question. As I say, we'll be all, and to be honest with you, we may never able to find it in our lifetime. Maybe the next generation able to find out about it. But that's going to be very difficult, especially politics may intervene with the right studies. They can suppress the studies because it's a huge thing when it comes to the agriculture and the food industry. That's why just don't think about that anybody can run easily this in the lab, because NIH may not gonna give you fund. And if you don't have fund and grant, how are you gonna do the research? And if you wanna get the money from outside, you can. It's a huge mafia. That's why many researchers, we have the same problem when it comes to diet soda. You know the diet soda. The studies about diet soda has been suppressed for many years. Even that we have all the artificial sweeteners that we see that it caused cancer in the animals model for years, but they never let them to be published because it's a huge industry. Yeah. Please.
I could see it when I was teaching.
Yeah, please.
I retired in 1968.
Oh, wonderful.
I'm sorry, 1998, I'm sorry.
Okay.
And I noticed that these little girls were developing breasts.
That's true, that's true, yeah.
7,
It's very unusual.
8 years
yeah.
old.
I know.
And you think about the chickens, and it was many of the Hispanic children.
That's true.
Who were
that's
on
true.
the, just the cheap diets, whatever their parents could buy. And it's just
It is true.
sickening.
It is true. The one thing about dementia, it's a questioning, because a lot of people ask this question. And again, I'm not a neuroscientist, by the way. I don't have any credits to really speak about that. But I just want to say that the questions that people ask about, did we have dementia in the past? Like in the older generation or ancestors, there was dementia. When we look at the history, when we look at the books, yes, in some stories we see, like, for example, somebody being forgetful and all this stuff. But the difference is longevity. The people or ancestors, they all died in their 50s and 60s. They're never able to make it to 80s, 90s. 80s, 90s, it was very unusual. And this is why, and again, as I said, the dementia when it starts to become more presenting when we live longer. That's what we really don't know, because a lot of people ask about, okay, what happened in the past? What happened in the past is that the people would not make it till 70 was really old age at that time, but now is the young age. And that's true, because that's the definition. We call 65 to 75, we call young geriatric. 75 to 85 we call middle-age geriatric, and 85 above we call old geriatric. And technically 65 to 75 was really young geriatric. But again, now the life has been changed. The life expectancy has been changed. That's why we see more presentation. We can't say that really from the past, but yes, I mean, during even like Dr. Alzheimer found the first case at age of 57 years old, at a lady that had the Alzheimer dementia. That's the way they found the disease. But maybe there was a disease there, but they've been diagnosed with other mental health condition. But there was a dementia. That's what that part we don't know. But there is no questions that the new generations are not healthier compared of the older generation.
Mm-hmm.
This is true, and a part of that because the way they eat
Right.
and the way they act, or more sedentary life as well, unfortunately. Yeah, please, question, yeah.
Do you do any consulting with Compassion and Choices?
Myself?
Yes, the nonprofit that is working
No,
on
no.
dementia and being able to specify, what your wishes are.
This is fantastic, yeah, that's true. No, I don't do it. I usually refer to the people that are specialized in that, but it's amazing topic. It's a very, very important things that the people need to know. Now, it's very interesting because you brought it up in another conversation is going on. Now, we don't want to talk about politics and healthcare, but one of the things is important about dementia. It's about, the discussion is about end of life condition. And I want to be very clear about it because a lot of wishes that we always encourage the people when you are still capable cognitively to express your wishes about how do you want it to be treated. In case if you get neurodegenerative disease, get dementia, and how do you want it to be treated at that stage. I've seen a lot of people say, well, if I get dementia, I don't want it to extend my life. I see that. This is the first reaction of a lot of my patients in telling me, if I get dementia, I don't want to continue the life. But we don't have law here that is supporting that, because technically we cannot terminate the life. Volunteer act of termination of life is not considered the people with dementia. One of the conditions, as you're familiar with that, in California from 2015, we have the act that if somebody has a poor prognosis disease, less than, we're done. The 16, I'm sorry about that, but less than 6 months of life, the doctor can refer that person to state to voluntarily terminate the life. But one of the conditions is there should not be any memory loss. This has become a very interesting topic, and I know that in Europe now it's one of the hot topic these days. That can the people prior to get to the neurodegenerative disease and dementia, can they make this decision? If they get dementia and diagnosed with dementia, they can terminate their life peacefully with dignity and not go toward the stages of the dementia. I personally, as a geriatrician, as a person being involved a lot in that, being invited in the pulse, I don't see it in our society that we're going to be there probably in the next decades. I can see it in the next decades, we will be there. We're not there yet. But again, we have to really looking for, the dementia, and I was saying that dementia is worse than cancer. Cancer is a wonderful disease compared to dementia. There is a reason for that. Because in cancer, you have answer. The oncologist is telling you, okay, chemotherapy, radiation, you have 2 layers to leave. Everybody has a sympathy with you. Everybody's going to go through the chemotherapy. But dementia, person lose identity, dignity, respect, everything. They're just, so I've seen that this tragedy a lot, even the kids or grandkids are scared of the grandparents. It's a very heartbreaking disease. And it's a huge suffer for not only the patients, but also the people and surrogate around. Now, there's a different topic for that. It's not about treatment, but I'm just saying that we need to, in the society, change our mentality about dementia. We need to understand, the people should understand this, how much suffer the person can take when they have this kind of neurodegenerative disease. And it's just too much. And unfortunately, it's going to take a long, long time decline till they finally die. It's really a painful dying process. And again, as a geriatrician, I always, whenever I've been invited to speaking about that, I've always been advocate of having the people understand this disease and have a solution finally. How can we help the people with dementia to at least die peacefully, with dignity and respect, rather than go through all this process? I'm not talking about a cost and all this stuff. This is a different topic, but my feeling is the Gen Z will change it. This is my impression is that they will change it. They will have some solution to change that, and that's going to be the society mentality that needs to be changed at the end.
Right.
Thank you so much. I appreciate it.